Oop. Thank you, guys. Sorry, the button was on my thing here that was going no sound. So thank you for catching that before I went 30 minutes without anybody hearing me. So welcome back, everybody. Dr. Twyman, board certified cardiologist, focusing on heart attack and stroke prevention. Been doing these Ask Me Anythings for the past 5 to 6 years. Apollo Cardiology, my practice, has been open for almost 6 years, and we exclusively focus on getting to the root cause of people's cardiovascular concerns and trying to help them not have heart attacks and strokes. So lots of great questions asked tonight, a lot of them about vascular disease and a lot of the testing that we do here in the office. So we'll jump into the first question here. So how often should you have a carotid ultrasound if you've had plaque previously? If you have 60,000 miles of blood vessels, you got to go looking at more than just one territory. So if you've previously had carotid plaque and you've not had surgery, then generally every 12 to 18 months is when I would recommend getting rescreened to assess to see is the stenosis stable or getting worse. But if you add a CIMT to it, the intimal medial thickness, you're going to assess the underlying part of the artery that has the area where if white blood cells and cholesterol get engaged, then there's going to be more inflammation in the vascular arteries, and you're more prone to continuing to lay down plaque. So typically 12 to 18 months is usually my recommendation. Is there a benefit to a CIMT if you're doing a CT angiogram? Yes, because sometimes people have plaque in one artery territory and not the other. Ballpark, there's about an 80% correlation between the two territories. So if you have a normal CIMT, 80% of the time you'll have a normal CT angiogram, but not always. So in my practice, we do carotid assessments, coronary assessments, abdominal aortic aneurysm assessments, ankle brachial indexes to assess if there's any peripheral arterial disease in the upper extremities. And then we also do some testing on the lower extremities. Does the vagus nerve play a part in cardiac health? Absolutely. The vagus nerve innervates the heart. It's the part of the heart that has an effect on slowing the heart rate down in the sinus node. The vagus nerve is very anti-inflammatory, so heavily infected by what's going on in your environment. And if your vagus nerve is underactive and your sympathetic drive is overactive, that can age the vascular system. You know, there are certain people who get vagal nerve stimulators for issues with their vascular system. Question, high calcium score, do you think it clearly, or what's your next step? You know, if you have a calcium score over 400, there's rarely a reason to do it clearly unless you're having symptoms and they're looking for a stenosis or the degree of blockage. If you have a high calcium score test, start treating. The calcium is stable. There's soft plaque that comes along with the calcium score test. That's the only benefit of doing a CT angiogram with the clearly is to see how much soft plaque is still present. But it may not be worth the radiation for many people. So just start treating the risk factors: endothelial dysfunction, glycocalyx disruption, oxidative stress, inflammation, dyslipidemia, metabolic disease, insulin resistance, uric acid homocysteine. Hundreds of things can damage the lining of the arteries. And if you do the proper testing, you usually can get to the root cause of what's driving that process. Next question, high calcium score test with high lipoprotein A and B, what to do? Lipoprotein A, you do not have great options other than apheresis to significantly lower LPA. The PCSK9 inhibitors may lower it by 20-30%, but that's not clinically significant. You probably have to lower LPA by 80 to 90% to have less events, and that's what the FDA's hurdle rate is in these phase 3 trials for the new drugs that lower LPA. Is they're going to have to show outcome data where people have less heart attacks, strokes, die, or end up in the hospital needing procedures. But for lipoprotein ApoB, or to say ApoB for short, ApoB is on the outside of all your LDL particles, VLDL particles, ILDL particles, and LPA. If you have a high calcium score test, you generally want your ApoB to be at least less than 70, probably ideally less than 55, which would put you between the 5th percentile. What to do? Depends on what they've tried in the past, but potentially statins, ezetimibe, PCSK9 inhibitors, and if statin intolerant, then Nexletol. Can red light therapy cause cancer to grow? Potentially. Not my area of expertise, and the training that I did, it was always recommended that red light therapy not be directed to any known tumors. If somebody has cancer, if you direct it away from the known tumors, like you're treating, face, treating blood vessels, that it may be okay, but you'd have to work with a doctor who's familiar with using photobiomodulation with somebody with cancer. How influential is the technician's skill level for an accurate CIMT result? It is important. There are different vendors that do these tests. The main ones are CardioSmart, Basal Labs, and I'll remember the other one in just a second. Some of them will have a sonographer do it. Other ones will have a medical assistant who's been trained in obtaining video images, and then the sonographer uses the software to measure the intimal medial thickness. It's generally best to be screened with the same piece of equipment, same sonographer year over year, or technician, so that you have an apples-to-apples comparison. If you switch up vendors, or potentially even switch up sonographers or scanners, you may get a different result. We do hundreds upon hundreds of CIMTs at Apollo Cardiology, so we have a pretty good baseline kind of standard of deviation from our results. So, but it is important. Question about K2 as a supplement to pair with natural vitamin D from the sun still is important. Vitamin D, one of its roles is to help push calcium that's coming in from the gut to where it needs to be, the bones and the teeth, and you need optimal vitamin K2 to have that be effective. So generally, from a vascular standpoint, use at least 180 micrograms of vitamin K2, MK7. It depends. If you have known vascular disease, sometimes you'll do it twice a day then. Next question. Super high cholesterol, 489. Don't want to take statin, 63-year-old alternative. Great question. The podcast that I did last week with Dr. Lyon, that'll be released hopefully in the next couple weeks. I talked about the keto CTA trial. That is probably something that you should look into because you may be a lean mass hyperresponder if you're metabolically healthy and had normal cholesterol levels before eating a keto/carnivore type diet. But if you've had a high cholesterol since your basically birth, then you have familial hyperlipidemia with these type of levels. This will not get better with diet or exercise. It will require some type of pharmaceutical intervention if you're open to it. But I always look at what is the health of the arteries first. If you have inflammation, oxidative stress in your arteries, and you're developing plaque, particularly soft plaque in your arteries, on a carotid scan or a CT coronary angiogram, you would like to see your lipids much under the 20th percentile. Total cholesterol doesn't matter much. You have to look at the lipoproteins, the LDL particles, the LPLA, ApoB. So look at a advanced panel with either Cleveland Heart Lab or Boston Heart Lab. Quest and LabCorp also do them. If you prefer not to take a statin, the other three drugs that have outcome data are ezetimibe, the PCSK9 inhibitors like Repatha and Praluent. Those are twice a month injections, and then the oral Nexletol. Circumstances where you would recommend a statin. It's always individualized to the patient. It is a tool. Statins work mainly by lowering HMG coreductase. That lowers cholesterol. Less lipoproteins are needing to be produced then. But it also helps the thickness of the glycocalyx, the force field that prevents the cholesterol particles from sticking to the arteries to begin with. It lowers hsCRP, so it lowers inflammation. And it may change the plaque characteristics from soft and vulnerable, likely to rupture, to hard calcified scars. So use it in the right individuals. If you've already had an event, heart attack, stroke, stents, bypass, those patients should be offered a statin unless they're allergic to them, because the outcome data is significant with these people. If they take them, they have significant reductions in their absolute risk reduction. Where the question comes into who should take them from primary prevention really depends on, do they actually have plaque in their arteries or not? So you'd want to do a CIMT, calcium score, CT angiogram to really know who is going to likely benefit, even if they've never had an event. But if people are worried about muscle symptoms, you can check vitamin D, CoQ10. You can check your thyroid function. You can check ApoE. You can check SLC-L1B1. There's a couple other genes you can check to see, are you more likely to have muscle symptoms with statins? Question, cleaning our arteries naturally. Is there a chance plaque chunks cause blockage stroke? I don't quite know what this question is asking. Plaque is a process that's going on for many years in the lining of the artery. There's inflammatory compounds, there's clot, there's white blood cells, there's cholesterol in these plaques. Think of them as like an abscess or pimple on the arterial wall. You're trying to cause a smooth muscle to kind of sandwich them into the artery, make them more stable. Sometimes the plaques will calcify, and that further stabilizes the plaque. When a plaque ruptures, then all the cellular debris inside a plaque spills into the bloodstream, and the blood clots, and those clots restrict blood flow downstream, but also those clots can go downstream and cause perfusion issues with the small microvessels. So the little thrombi occlude the small blood vessels downstream. But I don't know what cleaning out the arteries naturally means to you, but there are no things that I know of that are going to cause chunks to break off, from a plaque. Question's pretty funny. So, how bad is chocolate milk for the arteries if someone eats it nearly every day? Everybody depends. Are you insulin resistant? Do you have issues with saturated fat? What are your lipoproteins? What's your inflammatory load? Does it have an effect on your gut microbiome? Unknown to say that it's all good for everybody, or everybody should always avoid milk chocolate. If you're a professional bodybuilder, maybe you need that much protein, and you can utilize the glucose in the milk chocolate. Well, if you're relatively sedentary and already insulin resistant, maybe it should be more of a treat than anything else. So, question, does meat contribute to heart disease? The short answer is no. You are what the animal eats, so higher quality foods are important. But some people, the question is mostly going to come down to saturated fat. It's much maligned on social media often. The greatest majority of people, saturated fat does not significantly impact their lipoproteins. If it does, then it's your choice if you want to take medications to affect your lipoproteins or to change your diet. But most people have no problem with meat unless it's ethically a concern for them. All right. So my apologies for the IT glitch at the beginning. That was my fault for not pressing the button that unmutes my microphone here. So I want to show you a device that I will be putting in my stories in the next couple of days. This is the Connect QT. This is the latest and greatest home blood pressure monitoring device. It measures your brachial blood pressure with an inflatable cuff around your bicep. But the device also measures your central aortic blood pressure, and that's the blood pressure that your brain, heart, kidneys all sense. It gives other metrics of arterial stiffness. So it's basically a shrunk down version of some of the gear that we use in our office. It's going to be the best way for people to monitor their blood pressure at home going forward. So I'll be talking about that in my stories over the next few days. I finally got around to making a form that has some information about the retreat that I'll be doing at the Canyon Ranch in October and November later this year. The dates will be Friday, October 31st through Sunday, November 2nd. It'll be in Tucson, Arizona. There is no fee for this retreat. Basically, you get to hang out with me, go on hikes if you like, go to different classes that I attend, and if you want to meet me up for breakfast, you can do that. But you're, on your own to do the other activities you want to do. The Canyon Ranch, if you want to go to different workout classes or nutrition, counseling, be my guest. Again, there's no fee from my standpoint. You just have to be responsible for your travel and accommodations there. I will put a link up in my stories. Also, if you go to my website, drtwyman.com/retreat, there's a link to the form. Just an information form. No money is due or anything like that. Just to get a list of people who are potentially interested, who then I can send more information about the retreat. So if you're potentially interested, check out that link. It'll be in my story later today. My YouTube channel, I'm working on it to get some of the archives up and running. So got to get some of the AI tools working a little bit better, but I should have those up in the next day or two. So if you're looking for the archives of my previous Instagram lives and some of my long form videos, it's on the YouTube channel, drtwyman.tv. And we'll keep doing these every week. So next Monday, 6 p.m. Central Time, I'll be here to answer your questions, trying to keep you guys heart attack proof. So hope you have a great 4th of July and see you next Monday.